Yes, great. You covered a lot of really important topics that I think we should include in our group conversation now in the Q&A, so everyone can bring their cameras and open up your microphones. You talked a lot about different topics that Dr. Kaiser, so thank you for kind of putting it all together for us. I think that was a very nice discussion about these important points. One of those is high risk. And Karuna has a question about, they're confused about what high risk means. Is it based on the FISH test or someone's myeloma relapsing quickly or both? Can you, as a panel, talk about how you define high risk? And when you talk about ultra high risk, are you talking about double hit or triple hit, or like explain that to us as patients so we kind of understand what you're talking about subsetting patients in terms of risk?
Yeah, if I may take the question first, but I'm sure you'll say something to add as well. So I think the importance is really here that it's going to be the difficulty of opening the discussion up to this more complex quantitative grading of risk. I think you're absolutely right. By us using the label high risk or standard risk just as a binary term, I think it will not be fit for the future, in other words, because I think with different treatments and the treatments getting better, there may be, for example, patients whose tumors only have one high-risk lesion, which will see a massive improvement in their outcome. But those with double hits or triple hits might still see their disease, unfortunately, relapse significantly early. And I think it will be important that we get the language right over time. This is just so rapidly emerging at the moment that it's still a work in progress. And of course, this patient comment is absolutely right. We as professionals need to make this crystal clear. We in our study, for example, have taken the approach of really considering the double hits and the triple hits as this ultra high risk group in the trial and prospectively enrolled these groups. Because we are seeing, for example, that in our retrospective trial analysis from, for example, the UK myeloma 11 trial, patients with only one high-risk marker really already benefited quite substantially just by the introduction of Revlimid therapy, maintenance therapy after transplant, which unfortunately we know in the long run doesn't necessarily solve the problem of that type of high-risk disease, but it actually allows us to really address the question of those with the highest unmet need, i.e. those who unfortunately, even with Revlimid maintenance therapy, might only see quite a short first remission time. We felt that this first remission time is really something that is so important, because in that time, of course, not only is it important for the patient themselves to find their own balance again and to get the reassurance of how their life is going, but actually in that first remission time, we can probably achieve the longest remission time. And as we know, in that time, a lot can happen in terms of new developments. What Niels has shown, if during that time the next CAR T cell or bispecific antibody is approved, the first relapse might already go in a completely different way than what it might be going now. So I think these are groups that could be useful to narrow in on in the coming times, the double hits, the triple hits, if we speak about molecular risk, really. I hope that has answered the question to some extent.
Yeah,
Martin,
it helps. And
can
yes,
I
go
ask
ahead.
one question to Martin? When we talk about risk, we now focus mostly on genetic features, high-risk genetic features like deletion 17p or a double hit or a triple hit, extramedullary disease, presence of plasma cell leukemia. But do we also have to consider patient-related features when we look at high risk? What do you think about that? Or maybe in the future also features of the microenvironment when we are going to incorporate more and more immunotherapies upfront? So do we have to make our definition of high risk more broad than only focusing on the plasma cell, but also looking at the patient and at the microenvironment, for example, the immune system?
I think that's an excellent point, and I hope, of course, with your work and other people's work, there's so much data being generated at the moment that I'm sure that we're going to get these incorporated as well. I think what we are seeing at the moment is the starting point of really addressing patient subgroups more specifically, and of course, we can only start that for the areas where we have currently probably the most validated data. We have to say, for example, on the double hits, we have now validation across multiple trials, including now 40 as well, more than 4,000 patients in total. That gives us a basis to really prospectively look at that. And I think both the concept trial and the Optimum trial in the UK were now starting points that we hope that we can see more of that in the future. But I think it's exactly as in the same sense, just calling it high risk will not serve the purpose. We will have to find very precise definitions. In terms of patient factors, absolutely, I agree with you. Again, the question is, how do we precisely determine that so that we don't confuse ourselves and patients? So renal impairment is still a big issue. There is no question that patients with renal impairment at diagnosis, unfortunately, still have an inferior outcome than those without. But the treatment, of course, or the approaches that we need to take, that might be completely different ones. It's mostly probably around deliverability and toxicity of the treatment, and how much it is affected by kidney impairment. And I think, for example, that group could hopefully see a big improvement over time as well, with many of the monoclonal antibodies being perfectly tolerable in kidney impaired disease. So they might not need necessarily more intensive treatment. They might just need the treatment that is tolerable and compatible with kidney impairment. And I think that will hopefully be a big leap forward. But as I mentioned earlier as well, other factors like patient frailty are a big risk factor. But as Alessandro La Rocca showed at ASH, maybe for those, dose reduction is actually the right response in terms of, that was a trial, just to explain to the audience, where Revlimid was combined with dexamethasone as a standard ongoing treatment, or the experimental arm, the dexamethasone was taken out after a while, and patients only stayed on a lower dose of Revlimid. And actually those without the longer term steroids did better than those with the steroids. So less intensity for those patients with frailty was actually giving them a benefit in the long run. And I think this is why we need to get the definition of high risk mostly upfront correct, because all of those will need different strategies. And I think we are at the best chance now to really improve outcomes for a lot of these subgroups.
Yeah.
It seems like you have a lot of data. Yeah, I like what you're talking about, the microenvironment, adding that and everything else. I had another follow-up question, maybe Dr. Faisal, you can weigh in also. What her question was kind of like, if I relapse quickly, but I don't have any of these genetic markers on my FISH test, then am I high risk, and do I know why? Or how do you subset do you have patients like that? Or once they start relapsing quickly, they're starting to develop these new genetic hits or markers?
That's an excellent question, and it hits, I think Martin and Niels will agree, one of our absolutely burning questions. We still see some from the genetic profile and all what we measure and do stage standard risk patients who are, despite receiving the upfront innovative standard, who then experience an early relapse after high dose therapy in between the first 2 years under maintenance, ref maintenance. And this, we do see those patients. I think in our centers, we even do see them more often, as they are then referred to us and with the question, why is that and how could that happen and what can we do? And honestly, so far, I think I have no clear answer what those patients, how those patients are different to other standard risk patients. And they do not necessarily acquire genetically high risk features when you then do again a bone marrow. However, they are clearly sort of clinical high risk, was what we just discussed. And then it's getting extremely complicated because we know patients where we just, for example, I had patients when the daratumumab came up, and we had patients with an isolated biochemical relapse, however early underland maintenance. We tried sometimes to fully dose LAN, take the DAX in and the DARA. And we have patients then having still then a remission lasting longer than the initial remission with high dose chemotherapy. And then you have also patients where you reinitiate, like, for example, carfilzomib LANDAX, Mandara LANDAX, or PVD, pomalidomide, Bordedex, and you see that you cannot really hit the myeloma as you would like. And I think for especially those patients, we need those novel and emergent strategies. And therefore, we also waited for the positive CHMP vote, which was given yesterday for the first CAR-T in Europe. But again, at the time of relapse, it's not clear which patient goes which way. And this is an absolutely therapeutic challenge.
Mm-hmm. Yeah, but again, the importance of seeing a myeloma specialist, in my opinion, just for your very best care. Okay, Jody's asking a question, and I want to lump. Oh, go ahead.
To the outstanding outstanding reply of Dr. Weisel. I fully agree. This is patients with early relapse after transplant or after triplet induction therapy. They are high risk, irrespective of whether they have known high-risk cytogenetic abnormalities, and they are having an unmet medical need. So I think these patients need early access in clinical trials to very novel, very different drugs with novel mechanisms of action. And I'm very happy that we have now an increasing number of trials for this subset of patients that enables these patients to get CAR-T or bispecifics much earlier than what was otherwise possible. So we could enroll early relapsers in CAR-T cell protocols. And I think these patients already have longer duration of response than what they had with their previous transplant regimen, which is encouraging, I think. The follow-up is still short and we need more time, but I think these patients may benefit from T-cell redirection therapies that I discussed before.
Mm-hmm.
Maybe if you don't mind, I could also add a little bit. I mean, we have done work as well on these patients that don't have any genetic high-risk markers, and we did find that about 10 to 15% of these patients at diagnosis do have gene expression high-risk markers, and they are really independent. They cannot independently be identified by this from genetic high-risk. Now, the problem is, at the moment, I think there isn't necessarily a consistent access to this type of testing. But we found really this is really going to reduce probably the number of patients. If we had this, it would probably make us definitely wiser up front. It's quite a big part of the population that goes currently undetected by genetic testing alone. By the way, it's the other way around as well. There are some patients that we find only by genetics to be high risk, but not by gene expression profiling. They are different components of the molecular high risk part. Now, does that explain everything? No, I think I completely agree with my, two other speakers here, but I think there is a point for improved access to diagnostics for our patients. And I do think that we still are not having, unfortunately, a consistent access everywhere. We are, for example, trying at the moment with the regulators in the UK to put in an application that gene expression profiling could be accessible. It's a long way to get there. And we're always struggling with making the argument that it can be helpful for patients to know better at diagnosis. And I think in some sense, what I would hope for is if we improve access to diagnostics up front, it would hopefully reduce the stress for patients and healthcare professionals alike if we only find out at relapse. Now, will we always find it out? No, there will always, unfortunately, be patients where the disease changes at relapse. We have, for example, done a genetic study. We have found in 20% of patients, high-risk markers in the tumor are acquired at first relapse that were not present at diagnosis. We had a matched study, so we took 2 tumor biopsies, bone marrow biopsies. So that shows the scale. It's not, it will be a problem. And to be frank, a repeat bone marrow biopsy alone is not a standard everywhere at first relapse and a retesting. So that alone would give us probably a better confidence about that. And I think imaging can also add to that, because we do see patients, for example, that have after transplant, and we're doing this systematically now in our center. We're very lucky. We know that everyone has that whole body MRI after transplantation. And we do see patients that have an island of disease still present that is not producing a paraprotein or a light chain, but that's clearly there and gives the rise to the relapse to the early ones. So I think that goes more into the direction of MRD, but I think the imaging particularly adds a different quality to understanding more about these early relapses. And the earlier we detect them, I think the better we will be at directing therapy towards them.
Mm-hmm. Okay, great. We have a growing number of questions in the Q&A. So if you're not speaking and you want to answer a quick question in there, just so we get more questions answered, because we have about 15 minutes left. And I love your answers, and we wish we had hours with you, because this is what patients want, is to hear from people of your caliber. It's totally amazing, and thank you so much for doing this with us. So just a quick outline. There's the FISH test, there's the gene expression profiling test, and then there's the next generation sequencing test. So you're just saying earlier access to those tests, both at diagnosis and at relapse. And maybe that's where patients need to push, because I mean, they're more expensive, but relative to myeloma therapy that you're going to spend over your lifetime, they're very inexpensive. I mean, it's maybe, $2,000 or $3,000 for like an NGS test or something like that. So like, I totally agree. And because then you can subset patients and you can start studying them differently. And you can't do that if you don't have any. And just so patients know, if you get treated and you don't get those tests and you have no more myeloma to test, then you can't get these tests because there's no more myeloma to test. So yeah, very important point. Okay, I want to ask one more question from Jody, kind of in the context of this too, because non-secretory myeloma, or when you're not producing that protein, is sort of a challenge to treat because you have to do bone marrow biopsies every time. You can't test it in the blood. So father had a transplant that didn't work that well, induction care, RVD for induction, a second transplant, and then does that, I know you can't answer specific patient questions, but when you look at non-secretory patients that are more challenging, they can't really join clinical trials. So do you say change up the chemo and do a different mix, or do you say go to CAR T if it's been approved where you are? How do you see non-secretory myeloma? Because sometimes, is it considered in this high risk bucket?
If I may shortly try to start, we have a non-secretory myeloma is not per se high risk. We have patients behaving absolutely the same like secretory ones, then it's just a biologic feature. However, non-secretory patients accumulate a bit in patients with primary extramedullary disease or low secreting patients. So yeah, it's painful with the bone marrow. However, we have to say it's a bit then like treating leukemia, that you need repetitive bone marrow analysis. And Martin just mentioned very nicely the new imaging features, and the diffusion-weighted MRI or the PET-CTs can help us in monitoring this. So per se, I think normally we go forward with standard treatment like we do in secretory myeloma. However, we focus more on imaging, and then you take the method out, which is the best reflecting this particular patient and his disease, either MRI or PET-CT. And then you need repetitive bone marrows, but the imaging helps to monitor.
Yeah, I agree. I prefer in fact PET-CT or MRI. We typically do PET-CT over bone marrow biopsy to monitor non-secretory myeloma, because myeloma is sometimes so multifocal. So it can be very difficult to monitor response by sequential bone marrow biopsies, because sometimes you are in a focal lesion and sometimes your needle is next to the lesion. So that already gives a lot of variation. So I like to do the PET-CT scanning to monitor response. And of course, you look at all the other disease parameters, calcium and LDH and the blood values. And hopefully in the future, we get new tests for these patients, like soluble BCMA assessments that can be helpful as well.
And it's not always fully excluded to participate in clinical trials. In the most trial, yes, unfortunately, yes. But there are some trials also allowing, if you have a bidimensional measurement possible, that patients can be included. So it's worth to actively ask if there is a possibility to participate.
Okay, great. Okay,
and I think that goes, sorry.
Oh, no, go ahead.
And I think that goes, I completely agree with everything. I think that goes again towards the access to better diagnostics. So we are, for example, monitoring all of our oligosecretory patients, and we found there more than we thought at relapse as well with the diffusion-weighted MRI, which is, again, of course, particularly good because it picks up the diffuse disease infiltration as well. You could, I don't want to overstate it, but if there was a wide international access possibility to such imaging, which is not, there is no real barrier to it apart from effectively payment and people picking it up, because the protocols are all open access. Radiologists like to share that. There are standards that are published already. This barrier is not really one that is substantial as such. But if there was a pickup internationally, I think that we could see more of these trials that exactly Katja mentioned that would allow these patients in, because the moment that you can measure it, you can run a trial with patients with oligosecretory disease.
Yeah, and a follow-up question on the diffuse MRI. He's asking, does it require all new equipment? And then Jack was wondering, does it differentiate between active and non-active myeloma for the focal lesions?
Yes, so I think taking up the second point first, this is the most important revolution about the diffusion-weighted MRI over the traditional MRI, because MRI had for a long time the disadvantage that there wasn't a discrimination between active and inactive. Diffusion-weighted imaging shows the difference between active and inactive, and it shows it probably at higher resolution even than the PET-CT. This is really important. So our radiologists, when they're correctly trained, they can tell us this myeloma lesion has completely melted away. They can tell whether it has turned into liquid effectively, just dissolved. About the first question, it depends a bit, but actually the protocols that this international collaboration has developed is compatible definitely with different vendors of MRI machines. So as such, the MRI machine does not have to be a particularly fancy one. To be fair, apparently often the a little bit older ones are even better. The lower Tesla machines are better for this. They might need to get some coils, as it's called, which is actually just a simple metal coil that needs to be put on the body whilst the scan happens. But that should be a really minor investment, and it's really open access. Our radiologists, for example, are very happy to train outside parties, and they have done that, for example, for the whole of UK, more or less, which we have published on as well. The radiologists, once we have them on board, and I think this was something else, which was an amazing experience. We benefit so much if we get other experts on board. And if we get the radiology community on board, I think they can only help us and the patients to really have access to better diagnostics.
Mm-hmm. Okay, I want to move on a little bit and maybe start with Dr. Van der Donk about these bispecific antibody type questions. We have some questions like Susan's asking, could you use a bispecific antibody? You know, in CAR T, you have potentially this bridging period where you don't really want to, while these cells are getting produced, and you don't really want to stop treatment if your myeloma is very active. So could you use maybe a different target bispecific antibody for that period of time? And then there are a lot of questions about, you know, patients want to know comparative bispecifics versus CAR T. You know, Geraldine asked a question, could you get CAR T after stem cell transplant? The answer is yes. But how do you look at this as experts? Like, when would you suggest a patient do CAR T versus a bispecific?
Well, a lot of
that was a lot of questions. I'm trying to rapid fire because we're running out of time.
Yeah. Interesting questions. I think both CAR T and bispecifics are very promising new agents. They both use the power of the T cell to kill the tumor cells. And both have advantages and disadvantages. And we still need more time to fully see where the best place of these T cell redirection formats will be. I already mentioned the big plus of CAR T cell therapy is a one-shot therapy at the moment, although some studies are giving maintenance now after the CAR T cell infusion to promote persistence. So then the one shot is not true anymore. Bispecifics need to be given once weekly in most studies at the moment, but we are also looking at more patient-friendly administration formats, like in the beginning once weekly, then once every 2 weeks, then once every 4 weeks. When you look at patient populations, maybe patients with more rapidly progressive disease may benefit more from bispecifics because they can be directly given off the shelf, while maybe these rapidly progressive, heavily pretreated patients are not the best candidates for CAR T cell therapy, because indeed you need 6 to 8 weeks and sometimes even 10 weeks in Europe, because the cells need to be shipped from the US to us, and the T cells from us to the US, so it takes a couple of weeks extra. And for heavily pretreated patients without any treatment options, then CAR T cell therapy can be very problematic. And maybe for those patients, bridging with a new agent like a bispecific may be a good solution once they are available. When you look at the efficacy, so CAR T cells versus bispecifics, I think some of the bispecific data look very similar to what we see with some of the CAR T cells. In terms of efficacy. I think there are also CAR T cell products like cilta-cel where the depth of response seems to be superior to what we see with the bispecifics. But I think we need much more follow-up with the bispecifics. We need to be focusing also on the differences in patient populations. So it's very difficult to say which one is better. And I think both are very important, both are very effective. And I think it will become much more easy to implement these strategies when you go to earlier lines, because then bridging will be much more easier, for example, with CAR T cell therapy, because these patients are heavily pretreated, end-stage myeloma, but you can do a very effective bridging with a triplet. So in CARTITUDE-4 and in KarMMa-3, patients with earlier relapse can be offered CAR T cell therapy or standard of care. And here you can debulk the tumor very effectively with 1 or 2 courses of a very effective triplet regimen. And then you give the CAR T cells in a setting with low tumor load, which not only translates to lower cytokine release syndrome, but hopefully also to a lower neurotoxicity profile, as has been shown now for cilta-cel. So I think earlier lines of therapy will translate into a better toxicity profile, and hopefully with more fit T cells, also in a better efficacy profile. So I think we need data from all these studies that are ongoing to see what is the best strategy for which patient. And I think both are having a lot of advantages at this moment. So also the bispecifics are being integrated in upfront treatment. So first induction, transplant, and then there will be studies evaluating bispecifics as maintenance. There will be studies incorporating bispecifics as part of induction. For example, in high-risk patients, you can also sequence different types of bispecifics targeting BCMA or GPRC5D in high-risk patients to prevent antigen escape and resistance development. So, well, there are so many studies going on that the nearby future will learn how to best implement and use these strategies in our daily practice.
Yeah, it's amazing. And how you run those studies faster is your challenge, right? And to get the results faster. So
Yeah,
hopefully we can use new strategies like MRD testing or something
yeah,
as
exactly. I think that's very important, especially when you do the studies up front. The PFS is now so long, as discussed by Dr. Weisel. DRD already gives 5-year progression-free survival median. So also the new upfront studies incorporating daratumumab with VRD will lead to such long PFS duration that you need new endpoints such as MRD to get the drugs earlier to our patients.
Yes, definitely. Okay, I'm tempted to ask just one more question, but I can't decide because they're all such good questions. And I know we are ready for potentially our next group. But yeah, so, well, okay. Okay. Yeah, I don't know if you can stay on and answer some of the questions. I'm just challenged to know that. So I'll just ask Kathy's question because she was early in asking her question. Her husband had MGUS, had fatigue and abdominal issues, and the myeloma specialist is saying they're not related to MGUS. Can somebody just briefly address sometimes symptoms? Because I hear this a lot from MGUS patients, that they have symptoms that they believe are related to myeloma, but may not be. I don't know.
Sure, we know that there is the term what we call a monoclonal gammopathy of clinical significance, so that we see that we not have the classical multiple myeloma or smoldering myeloma, however, that the underlying plasma cell clone does make clearly problems. And this is a rare but significant case and disease, and I would recommend here to consult really an expert who treats many myeloma patients, because this is really rare. And then one have to talk about an individual concept. Sometimes it is necessary to hit the underlying plasma cell clone, but then you have to carefully decide how you do that and with which strategy. But I would encourage to really go here in a huge myeloma center where those patients are kind of accumulated.
Okay, great. And then one more question from Rosalind. I'm sorry. And then I'm going to thank you for joining. I get so tempted. So if a patient has rapidly rising light chains, is it a sign of more aggressive myeloma? When you see that, do you just put it in context of the M protein rising, or how do you do that for when you look at patients' data or labs?
It's not per se necessarily a sign of very high risk disease, but of course it does often trigger the need to start treatment earlier or consider a change in treatment earlier. It does not necessarily predict the length of the treatment to the next therapy, but there is, of course, a subgroup of patients within that will have more aggressive disease. So we do know that this disease that is proliferating to some extent can develop resistance mechanisms earlier as well. But it's not per se said that those where the light chains are rising quickly are all difficult to treat.
Mm-hmm. Okay. Well, with that, I will just say thank you. Thank you so much for joining us. The information that you're sharing from ASCO and EHA are wonderful. It just is such exciting progress. So I just want to thank you as myeloma researchers for all you are doing to run these studies. And each of you has a different specialty, and I just appreciate the variety and um, the depth at which you're doing this for your myeloma patients. So I just want to thank you for participating today on this call, for sharing your knowledge, your time, and your talents with patients, and for helping us all try to get closer to this cure, because what you're doing is so very important.